time, I have truly admired how so many individuals, families, and organizations and companies have done all they can to extend themselves. And the Brown School wanted to do our part. So with so many people under stay-at-home orders, we wanted to offer the opportunity to open our virtual doors and share with you some opportunities of professional development or even perhaps learning about something new. So every Tuesday and Thursday at 12:30 for the next 5 weeks, we'll be featuring some of the Brown School's most well-renowned social work, public health, and social policy faculty. And I want to thank Janet Gillow and the professional development team for pulling this series together so quickly. This Thursday at 12:30, we'll be featuring Dean Mary McKay, a federally funded researcher who has spent her career developing evidence-based family strengthening interventions that have been translated for cultural contexts around the world, including Uganda, Argentina, and the Philippines. Her talk, titled "I Went for an Intake and Never Went Back," will explore how mental health care providers can best engage with families so that they're more likely to participate in mental health services. And today, to launch our series, we have one of my favorite faculty members, Dr. Nancy Morrow-Howell. She is the Betty Bowfinger Brown Distinguished Professor of Social Policy. She's an international leader in gerontology, known for her work on productive engagement of older adults. And as the director of the university's Harvey A. Friedman Center for Aging, she promotes gerontological research and education across disciplines and schools. And today she's prepared a special talk, COVID-19 and Age, Risk and Opportunities. On one note, since we have almost 300 registered participants today, we have muted your microphones. If you have a question, please type them into the general chat box. Janet and I will be monitoring them and will share them with Professor Morrow-Howell during the Q&A. We will also be posting a recording of this talk on the Brown School website. So without further ado, please welcome Professor Nancy Morrow-Howell, and thank you, Nancy, for being here and joining us today.
Thank you, Gary and Janet, and everyone that's tuned in. I hope you can hear me. Janet and Gary, you let me know if there's any issues, please. I'm assuming we're good. And I already changed the title of my talk, Gary. Really thinking about the intersection of what we're experiencing now in age, what age has to do with this. I need to acknowledge my wonderful colleagues, all of us at WashU, focused on issues of aging society. Here's an outline of our presentation today. You can look at that while I tell you that I'm a social worker. I'm a social gerontologist. I'm not an MD or an infectious disease specialist. So as you can see from this outline, I'll be talking a lot about the social aspects of this pandemic and how I think about it as a gerontologist. But a more important caveat is this is such a moving target, you know that. Data that we pulled several days ago is out of date. So it's constantly moving. So I want to give this caveat. We also had to, and it was thanks to my colleague at GSA, even take something off that was fake news. We had seen it in several places and had worked it into this presentation and learned later it wasn't true. So with all those caveats, I think that one thing is clear, that there is evidence that there's a very strong relationship between age and dying from this virus. As age goes up, severity of illness and mortality goes up. Here's the US. It's helpful to remember that about 15% of Americans are over the age of 65. So it's 15% of our populations, and 80% of the deaths from the virus are folks over the age of 65. Look at that ICU admissions. About half of the ICU admissions, and again, this is from last week, half of the ICU admissions are under age 65. But only 20% of under 65 age group seems to be dying at this point. So this shows that a person is more likely to recover even if they've been in the ICU if they're under the age of 65. We know the most about China, and here is China. Again, the take home is there's a linear trend between aging and mortality. Now, only 9% of China's population is over the age of 65. China is a rapidly aging country, but it's not that old of a country yet. But here you'll see that 31% of confirmed cases are over 60, and 81% of the deaths are over 60. Italy, a very, very hard hit country and a very old country. Clear linear relationship of age and death rate. The average age of an Italian person who died in this epidemic has been 80 to date, 80 years old. People are looking at that comparatively high death rate in Italy and thinking, what about this country? And some of the best explanations to date, and they're all emerging, is that 23% of its population is over the age of 65. It's one of our oldest countries in terms of age distribution. Lots more older people proportionally to begin with, and much more intergenerational mingling and living that has to do with virus transmission. Also high rates of smoking and a healthcare system that was overrun. So you can see many factors play into these variations that we're going to see by country over time: age of the population, rates of testing, response of the healthcare system, and actually lifestyle behaviors. And you might have seen that in this country, some people early on talked about maybe the effects of vaping and how that might play out. So it is clear, older people are more likely to die. So what is it about age? Why is age linked to this virus? And it's not really age per se, but it's other conditions that are associated with age. It turns out that the underlying health and immune system of a person is the real issue. But older people are more likely to have underlying health conditions. We call it multimorbidity, and to have compromised immune systems. Another social factor, older adults are more likely to live in congregate settings. We are hearing about nursing homes, retirement communities, and cruise ships, where disproportionate numbers of consumers are older adults. These close quarters put people at increased risk. That's why here and across the nation, we've emptied out our dorms on college campuses. In regards to nursing homes, the most physically frail people in our society live in nursing homes, very close quarters with staff going between the rooms. It's a bad setup for sharing viruses. And this is nothing new to the nursing home industry, the high risk of sharing viruses. But this is a new situation with corona. Seems to be highly infectious, no immunity, limited knowledge about the course of the disease, no interventions, etc. This slide shows the correlation between chronic conditions and the virus, and it takes age out of it. So this is in Italy. 3/4 of this pie, and this pie represents the total number of deaths in Italy. 3/4 of this pie, the people had 2 or more illnesses. So an interesting piece of information here also shows that underlying illness have more of a causal link to the mortality from the virus than age. Now, warning, this is really early data here about New York. It was when there was just 200 deaths, when it was the first 200 deaths in New York City. But 95% of those first deaths from corona had underlying health conditions. About half those people were under the age of 75, half over the age of 75. In other words, almost half of New York deaths were in that younger category, but 95% of the deaths had underlying health issues. So the take home is that younger people with underlying health conditions are also at risk. So bottom line, it's not age per se, but age with weaker immune systems, more chronic health conditions, and living in residential settings. So chronological age is not an indicator in and of itself. I've been telling people this is about how healthy you are, not about how old you are. But I would like to step back and mention 2 things about age. One, people always ask, well, how old is old? There's no definition of old. No gerontologist is going to tell you what old is. It depends on country and culture and individuals. So for example, some countries with the shortest life expectancy classify people 55 and older as old. And in China, you saw their data was on people 60 and older. In China, old is often considered folks 60 and above. And here in the US, it's 65 that we begin to think about some demarcation for later life. But the second point to clarify, the most important point, is that Americans over the age of 65 are more heterogeneous than any other age group in this country. That is, the people over the age of 60 or 65, a total mixed bag of physical, mental, social, economic, cognitive health. So take two 70-year-olds can be very different. One as fit and functional as ever in their lives, and is the 40-year-old person jogging next to them, and then look at another 70-year-old who could be in very poor health and very bad shape. So chronological age is widely used as a proxy, but it is often a very bad indicator of a person's health and functioning. So there is clearly a wide range of health and functioning among the older population. And I'm not a gerontologist who likes to point out exceptions, outlying people like the 80-year-old that's still running marathons or the 100-year-old that's still working. That's not us. Those exceptions aren't the usual folks in our lives. But I couldn't resist these exceptions. There's currently people living amongst us who lived through the 1918 Spanish flu. As a gerontologist, I really appreciate and value a life course perspective that highlights strengths and resiliency of older people. And I just checked them this morning. The oldest living person in the US today is Hester Ford. She was 13 during the Spanish flu outbreak. And I love this Spanish flu survivor telling us this outbreak is no joke, that we need to be careful. And also notice the old newspaper teaching us how to wash our hands. So no new news there. And these exceptional people who lived through the 18 Spanish flu, two people have been featured in our news who made it through this, who contracted the virus and survived at 105 and 101. And there was also a story about a 108-year-old who did live through the Spanish flu and died of the coronavirus. So just of interest, there's going to be a lot of very interesting human stories that come out of this crisis. But a major point of this presentation is that this pandemic is exacerbating several isms. And my heart goes out to my colleagues and students here who are experiencing xenophobia and are being insulted and threatened because they are from Asia or Asian descent. But today we are focusing on ageism, which is also rearing its ugly head in the face of this crisis. We are a very ageist society, so it's not that much of a stretch to know that ageism is going to be highlighted. Many things about this pandemic have been attributed to ageism, to reduced concern about and value attributed to older people. Countries were slow to move on dealing with the virus because, as this headline, only old people were at risk. Treatment and mitigation protocols have been more adequately developed for children and youth in certain hospitals, and saving the economy may be more important than saving these older lives, we have heard. We have even heard the old phrase of thinning the herd. And of course, the hashtag boomer remover. So ageism is evident in our media and in our discussions. An interesting article that just came out in the Atlantic, ageism is making the pandemic worse. In this article, Dr. Louise Aronson also points out that internal ageism is at play. Internal ageism is ageist attitudes that older people hold themselves about aging. And she points out that some older people fail to identify as old and at risk because it means acknowledging the reality of their age. And she states that many of us tried not to be perceived as old and not take necessary steps to protect ourselves. Dr. Aronson also points out that ageism is dangerous in the face of this pandemic. First of all, it puts younger people at risk because younger people aren't as serious about the threat. In more recent days in this country, it's become more obvious that young people, even children, can die from this infection. So the message that people of all ages must take this seriously is becoming more clear. But not that long ago, kids on the beaches of Florida is an image that we won't forget, and college kids declaring that we won't let the coronavirus keep us from partying. So young people feeling invincible and not vulnerable puts them at risk in the face of this epidemic. But younger people who don't feel as at risk are also less motivated to pursue the common good. So ageist ideas about COVID-19 have been related to unsafe behavior by younger adults who don't feel like they're at risk and that they'll be fine. If I get it, I get it. We heard on national TV. Yet failure to comply with social distancing guidelines threatens older adults who are at higher risk of dying. In other words, the young partiers perhaps on a Florida beach think that this is not about me. It's just about old people, so they might feel less motivated and less likely to play their vital role in mitigation. I think that an interesting point on this slide, maybe I didn't put it on that slide, is that modeling, our data suggests that the impact of distancing among low-risk people, i.e. young people, is more important to decreasing transmission than distancing of higher risk people, because higher risk people are less likely to be moving around. They're less likely to be going into crowds before we got a handle on that. So the idea that social distancing is more important among the folks who are less threatened individually by the disease. So in sum, ideas about ageism and age stereotypes hurts younger people, and it hurts older people when young people don't think that this is about them. Another area where ageism has raised its head is when people are thinking about rationing care. Rationing care was a necessity in Italy, and I hope not here shortly, but when there's too few ICU beds and ventilators, care is rationed, and age is brought into these discussions. So look at these two quotes here. It may become necessary to establish an age limit for access to intensive care, in that first one. And in New York, large groups of hospitals are consulting with ethicists to figure out how to set priorities. Dramatically different, so patients suffering from the same disease, but with dramatically different chances of survival based on age, medical history, and underlying conditions. So age as a criteria raises its head in these scenarios where rationing of ICU beds and ventilators may be necessary. This has raised some discussions about what older adults think about rationing care. And rather crudely stated, what do older adults say about sacrificing their lives? If you ask an older person about voluntarily sacrificing scarce resources for younger people, you're going to get different answers. As I said, a very heterogeneous group of people from all walks of life, and there's not going to be one answer. In fact, I put up 3 quotes. The first being, no way, I am healthy and happy and I have no intention of stepping aside. The middle quote is, it depends if I can be assured that it's my grandchildren and children that I'm saving. Yes. And the last one is, of course, as an older person, I would sacrifice. And as you know, the governor of Texas made this comment about senior citizens sacrificing. So if we did a survey of older adults, we're going to hear all kinds of things. There's not going to be one voice. But we do know that to the extent possible, triaging is talked about as being age neutral. And that decisions are made about chances of survival. So here's a couple statements from my colleagues at GSA. The first one saying, it's not just older people, but if we start talking about chances of survival, poor, homeless populations who are vulnerable in specific ways also have less chance of survival. So was warning against sort of the moral decay of thinking about even chances of survival. I love this observation from David Eckert, a colleague of mine, that it should not, if age-based criteria for valuing human life guides us, then Dr. Fauci, who has been our face of science and medicine in this crisis, who's going to be 80 soon, would be at risk. I want to talk a little bit about disproportionate burden that older adults are also facing from social distancing. It's very important that older adults social distance, and we heard that more so to protect them from getting the virus that may have more severe consequences. But it's well publicized that one of the most important acts to end the spread of the virus is to put people puts people at risk of isolation, and indeed older adults have a disproportionate burden. We know that isolation is bad for our health, physical, emotional, cognitive. We know that older adults are more likely to be isolated, and now they are more pressed to isolate because of the consequences of getting the virus. No visitors into residential facilities, no contact with grandchildren. So more pressed to isolate, just as they're more likely to be socially disconnected to begin with. I don't like to talk about older adults in general, because remember, it's a very heterogeneous group, but as a demographic, if we were going to describe social connections, older adults, people over the age of 65 in this country, have thinner, we call them thinner social networks through deaths of partners and friends, no work connections due to retirement, limited transportation options for some who have given up driving, more likely to live alone. We have known this a long time before this epidemic, that older adults are at high risk for social isolation. But this distancing puts further strain on these weakened social connections. So in sum, life stage can exacerbate the negative effects of social distancing on older adults. So how can we resist ageism and age stereotype in this time of COVID-19? First of all, we need to be aware that ageism is so ingrained and accepted that we fail to see it and react to it. From the Irish Times, this writer complained, what other demographic would be represented so crudely without serious blowback? I take this to mean that we would never accept identifying vulnerable people for triaging or for less concern or compassion by any other demographic characteristic, by class, by education, by cognitive capacity. There would be blowback, as this author pointed out. But when we use age, we don't get that same kind of reaction. We also must resist the allure of chronological age as a primary definer of people. Age tells us nothing about a person's compassion, wisdom, resilience, battling heart, as this next quote says. And finally, our global leaders have warned about the moral decay of devaluing older people. So it's just raising awareness, I think, is the first step in resisting ageism in the time of any kind of crisis, and specifically this crisis. The next thing we can do is confront age stereotyping through the way we talk and through the stories that we tell, the narrative that we use. We need to reduce language that is otherizing. We need to reduce stories that's us versus them. For example, my friends at Reframing Aging give us this language. This is all about individual actions, washing our hands, social distancing, maybe wearing a mask. Those are individual behaviors. But how can we talk about them as they relate to the common good? When we wash our hands, we protect everyone in our community. So change the narrative away from otherizing, away from us and them to we're all in this together, which we see a lot of growing these days in the message that we're receiving. But we need to be descriptive beyond age. For example, here's another quote from Reframing Aging. There's a lot of people at increased risk. Children who are out of school without lunches, restaurant workers without a paycheck, healthcare workers on the front line, people who are experiencing isolation and anxiety, people with underlying health conditions. Those are better descriptors of who's at risk than just talking about older people. How can we ensure that all of us are safe and as well as we can be? I'm very interested in this concept of fostering intergenerational solidarity. How can we foster solidarity rather than intergenerational divide at this time? We can promote, spotlight, and celebrate intergenerational acts of service and concern. For example, here, the calling back of retired healthcare professionals and organizing, young people organizing to take care of older adults who may be socially isolated. We need to celebrate and normalize this intergenerational concern. Check out this meme. I'm not sure how I feel about it. Your grandparents were called to war. So here's a young guy laying on a couch. You're being asked to sit on a couch. You can do this. I find it humorous. I find it entertaining. It's also sort of based on shame. So I'm not sure, but the more we can talk about taking care of each other and increasing intergenerational solidarity, I think the better we will be. Thinking about recovery in older adults. When we get through this, there's going to be some aftermath. The reframing aging experts around the country are thinking that we're going to have a setback, that we've been trying to confront this image of old age as a state of frailty and vulnerability. We're going to have some setback in terms of that national conversation if we're not careful. Number two, we know that the economic, the job loss scene is going to affect people differentially. And from past experiences, older adults who are forced out or shut out of the economy at this point, like so many people of all ages are, older adults are going to have a harder time getting back in reemployment of older workers. We know that age discrimination in the workforce makes it harder to re-enter the workforce after one has left it. We don't know yet what the effects of the stock market decline is going to be on retirement savings, but some folks are watching and worrying to death about the money that they have put aside to live on outside of the workforce. An interesting one is the longer term effects of isolation and the longer term effects of physically having the virus. We don't know about those things. Probably it depends on how long this goes on, but these will have repercussions for years to come with the current cohort of older adults. And one interesting one that's becoming part of our more and more every day, the conversation, is the disruption to routine care. You all know people whose elective surgery has been postponed, whose well visit to a doctor has been postponed. Geriatrician friends of ours are talking about how unhealthy diets due to living on foods, living on pre-prepared food and lack of exercise programs. They're seeing blood pressures and diabetes that are being held at bay by healthy lifestyles or going down the tubes. The fear, some people are using medicines wrongly to extend it, taking half doses or saving their medicine with fear that they might not be able to get a dose prescription refilled. So what are the long-term effects of this disruption of usual care, medical care, but also usual community and community services? A friend of mine was telling me that hospice workers are being held back and people aren't able to get the pastoral counseling that they may need, their families may need. So a lot of long-term effects, things related to outside the virus. These are sort of the problem things that we're going to have to focus on. It's also a time to think about how we can maximize what's going on now for the sake of all of us, including older adults. People have asked how increased virtual contact might strengthen our family relationships. Video conferencing and calling, texting, people will be more concerned than usual about each other. The effects of social isolation, the problem of social isolation is being brought to the forefront, and hopefully it will galvanize our efforts to reduce social isolation among everyone, including older adults who are at greater risk. People have told me that people are getting their paperwork together, their advanced planning, their wills, their medical directives. That's a good thing. We always do it in time of crisis, but maybe now we'll be more attuned to doing it because we all, who knows clearly when we're going to need it, and advanced care planning will become more commonplace and accepted. All of us have been pushed into online platforms. All of us at the Brown School are teaching online for the first time, whether we want to or not, and we're all going to be more ready for telemedicine, for telecommuting when we work longer. So this jump to online platforms will hopefully be something that we can build on in a positive way. And a friend of ours pointed out, boy, we can't wait to go back into a crowd of people and go to a bar. So greater appreciation of the good things in life might come out of this as well. I'm sure there's more. I'd love to hear how we could make this list longer and pay attention to ways to come out of the other side of this in a stronger position for older adults and all of us. There's lots and lots of resources out there that have been developed online that we can send people if we need. This happens to be from our City of St. Louis Health Department. There's a number there, but there's the area agencies on aging in this area and across the country are ready and willing to share information or help. If you feel like you need some help finding some resources, let us know. We can try to connect you to those online resources. I think with that, I am going to stop and see what kind of reactions and thoughts people are having, Janet and Gary, and then we can come back to some of this.
Great. Thank you so much, Nancy. That's incredibly informative and thought-provoking. I want to let our viewers, of which we have over 170 right now, you can ask a question and pose a question by putting it in the chat box. To access the chat box, if you go to the bottom of your screen, you'll see a little like speech bubble with the word chat under it. If you click that, the chat section of the Zoom will open up and you can type your questions right in there, and both Janet and I are monitoring those questions, so feel free to jump right in. And so we do have one question that's asking that due to some of the information that's been shared about COVID-19 and the lower fatality rates than have been reported for SARS and MERS, do you think the situation is being overhyped, and should those without risk factors be forced to isolate?
Wow, you are really asking hard questions. I wish we could talk instead of thinking that I have the answer. I do know that my colleagues that are talking about the virus itself do think it has some very big differences with SARS. And they also have pointed out that the regions that were hardest hit by SARS are much more comfortable, and normative behavior would be to wear masks, and that has helped some countries do better than others. What was the question? Oh, death rates. I'm not sure we know the death rate of this country. You can see how high it was in Italy, but it had a lot of forces that were driving that up that I mentioned. I think today I saw from a colleague, and I don't know if this is right, it's what I saw from one of our epidemiologists, I'm looking up this, that hospital rates may be about 10% of people that are identified as having the virus. And the average death rate may be about 1% of people that are infected. We know that's a lot higher than other influenzas. I don't know what the SARS death rate was, to be honest.
And so,
if it's if it's overhyped, we're still talking about what, 100 to 200,000 people in this country dying.
And so I recognize you're an expert in ageism and not so much in disease management, but the question also asks, do you think that those with low risk factors should be forced to isolate?
I think the answer that I'm hearing is yes, because of the fact that they are more likely to be the high spreaders of the disease. That was that one quote that I showed you. The people at the lower risk are the most important of the people to stay away from other people, because they are the people that could be spreading it without knowing that they have symptoms, with having very mild symptoms, and the more ones to be out and about. So I think the best guess of our public health experts is yes.
Someone wanted to share that for St. Louis County, they have information and resources that are available at stlcorona.com. Here's a question. What about elderly who do not believe the virus is real and rely on religion to see them through? What is
Yeah,
the best
right,
way to
yeah.
provide them information?
Boy, talk about a tough one. We've seen pictures of people that are putting their, their religious belief above staying away from people. I heard, and you guys know as much as I do from what you're hearing, that we are moving more aggressively towards trying to stop those congregations. I think that we have to give people, meet their needs for spirituality and religion by online and one-to-one contact via the phone. And some people of any age aren't convinced that they are at risk.
Mm-hmm.
I don't know if we should just attribute that to all older folks. I think when you look at large congregations of people, it's a real mixed bag of age. So I think everybody needs to somehow figure out how to have their spiritual needs met virtually during this short period, not short, but shorter than it could be time if we all are able to accomplish the social distancing.
Yeah. I just want to share with everyone too that a recording of this open classroom will be posted on the Brown School website, and the slides will be connected to the recording as well. So you'll be able to watch this on whole. We have a couple more questions coming in. So do you think that this pandemic will alert medical schools and professionals that additional training about working with older adults is so critical?
Well, I wish. As you know, geriatrics is one of our smaller specialties. Who has a handful of geriatricians, and they are working overtime. So it is not a well-attended specialty. There's a lot of reasons for that, but I think their knowledge base right now is showing itself in terms of our geriatricians consult across the hospital when an older adult has any issue going on, and they're experts on use of multiple medications, multiple morbidity, cognitive function in the face of an illness. This is what they know about, and there aren't enough of them. So if this epidemic would lead to that, that would be a very positive outcome. I'm going to add that to my list of positive outcomes.
We have another question
idea.
here from James Kelly, who says, do you know of any efforts to create resources for older adults aging in place to increase their ability to monitor their health at home? And what challenges or changes to older adults monitoring their health and professionals providing healthcare in homes do you see as a result of COVID-19?
Self-monitoring. That's what I was so afraid that home care workers, home care workers are still on the front line. They are going into people's homes to check, to give the care they usually do, working with medicines and infections, and even just helping people with food and grooming. I was talking to one of our leaders yesterday in this community, and home care workers are on the front line going into people's homes. When that is threatened because of a home care worker being sick, the monitoring, it's going to rely on self-monitoring more, families and others. I'm not sure it's happening very well. I don't know what the answer is to but we sure should be. And I guess any kind of telemedicine or individual self-education, self-management stuff I should also add that list to something positive that could come up. And that would be increases in our effort to have people self-manage their disease. And I'm sure missing that we can't have a discussion, because I know one of the persons listening has a much better answer than that works in this industry. But it is certainly a great idea.
So there's been a lot of misinformation over Corona and social distancing recently. When this induces ageism, how can we quell this misinformation targeting ageism and coronavirus, and how can it be handled effectively? We have some great questions coming out of this.
Yes. Well, I think I heard the question is how can we confront something that's ageist? I think we have to start being more descriptive. Describe what the situation is. It's kind of that this person has, what's putting the person at risk. It's not age per se. That's what we have to be confronting. It's not age per se. It's other risk factors associated with age. And it's, again, for every, fit and functional person that beats the virus that's 80, there's another person who doesn't. So how to be accurate when we describe people and situations, and also how to increase language about the common good. Kind of lost track of that question, Gary. What was that?
Yeah, no, you absolutely answered it. Here's another great question. When thinking about people over 60, many of them are raising our young people and have added stress of having to go into the community and get food and needed items for themselves and the children they are caring for. Do you know if articles surrounding stress and the immune system, and do you know of any programs that are grocery shopping for this population so that older adults aren't putting their risk at health to care for those?
Gosh, specific resources. I know we'll have a record of that question. I want to look up specific resources. There are definitely, for example, custodial grandparenting support programs around. I don't have any specific resources at the top of my head, but I bet we could find them. So I'd like to see if we could get that out to whoever asked that question, or more generally. A couple of things about custodial grandparents and grandparents in general. Very interesting. They do such important critical service. Let's talk about custodial grandparents first that are living, that are raising, primarily responsible for their kids. There's no way they're not doing what they've always done. And they are needing to deal with, having the kids at home and homeschooling and all of that. So increased stress on custodial grandparents. At the same time, grandparents who are just providing care for their kids, if they have their kids every day while their person is working, and let's assume still working, maybe going out to be in a store that's still open, a food service, they are really, we've been told, don't be around our grandkids. So people like me aren't seeing our grandkids. But families where that's really a hardship are really at increased risk and need support. But these grandparents provide vital child care, and they're very motivated to keep doing that through all of this.
Yeah. Can you talk about possible opportunities about intergenerational solidarity when addressing this?
I do think that there's a lot of programs. A student at WashU has a program that I'm going to forget the names. I think it's Students to Seniors, something like that. Many programs that have existed, but they're getting new life breathed into them, where it's younger and older people virtually connecting to support each other, and younger people running errands for others. So there are such programs in existence. Again, I'd like to make a list of those and make those available to people. And my colleagues at the Village, who I'm hoping are on the line, are very interested in trying to help people in the community through this.
What I can see too in the chat room is that there are those that are posting resources for attendees that may be interested. So I just encourage folks to take a look at their chat box, and then also when you're posting, just make sure that you have the setting to all panelists and attendees. That way everyone can see what it is that you're posting. A lot of folks are just posting to the panelists, and then that's only the 4 or 5 of us can see that.
I mean, maybe Gary and Janet, I could get those collected and add to them with our staff at the Center for Aging, and minimally we could post it on our website. I don't know if we can send things to people who attended or who want, but we can try to share that more widely.
Yes, we will absolutely do that, and we'll find a way, because I know over the course of this series, a lot of really incredible information is going to be gathered, and we'll find a way to connect it, those links and information to the postings of these webinars so that folks can have access to all of it.
Absolutely. And Nancy, if there's anything in particular that you want to share with the folks who had RSVP'd for this talk, we do have everybody's email very easily done.
Oh, good. Good, I'd like to.
I'm gonna jump right back into the questions, because there's really a lot of really fantastic questions being posted. Do you think there could be a negative impact from individuals that might be at a lower risk that are working for delivery services coming in contact with more vulnerable populations as we see a rise in delivery services for groceries and takeout, et cetera? Do you think this will help or hinder the spread of COVID-19?
Well, I mean, we need these services, right? And we all are worrying about the Instacart people right now who are feeling that they're vulnerable, and and the people that are getting food are vulnerable. We've gotten protocols of how to wipe down our food and all of that. So the answer to all that is yes, that there are vulnerabilities, but people also need food. So I think it's just minimizing the risk the best that we can on both ends, the deliverers and the receivers, and forge on with getting people food.
Mm-hmm. And since, Nancy, social policy is kind of your area of expertise, we have a question about how the information that we're learning from this crisis can better inform advocacy and policy to meet the needs of an aging population.
I think that this crisis is, presenting many opportunities for policy. Hopefully, healthcare policy and access. We're going to pay for people to be tested. We're going to pay for people when they're off of work. Policies that it could strengthen our safety net for everybody, including older adults, I think is what people are thinking about right now. I was just in a meeting with our WashU's Institute of Public Health Center for Health Policy and Economics, and people are beginning to talk about what data can we present that's going to bolster our arguments for what to do now, but what to do in the future so that our safety nets are strengthened.
Question, with the census underway, what are the impacts of COVID-19 for the response rate of the census?
Yeah, good question. The City of St. Louis Area Agency on Aging put out a COVID-19 informational flyer for older adults specifically. That's who they serve. One side was, here's how to take all the necessary precautions, and the other side was, and please do the census. So there's concern that people are not that we're going to be pushed to an online response more than we were expecting. So it is a concern. I don't know what the effect is going to be, but I'm sure people that work for the government are scrambling to know that. So it's another good piece of information to put out in terms of our health communications and public service announcements.
So we have time for maybe one or two.
Flyer.
I'm so
I
sorry.
was going to say that's one thing I can share is that information sheet that was coming out from Area Agency that had COVID-19 stuff on the front and census stuff on the back.
We have time for maybe one or two more questions, so feel free to type them in the chat box. And I also want to say thank you to all of the attendees who are posting all kinds of resources, websites, and phone numbers.
Yeah, I can't wait to see them.
Folks that they can utilize to be able to access resources for older adults. So, Nancy, I'm wondering if you have any just like closing thoughts you want to share, and then I want to, introduce Dean McKay to share a few words and maybe talk a little bit about her talk that's coming up on Thursday.
Well, my closing thoughts is I'm frustrated that we can't have a group discussion. I don't know so many of these really good questions and answers, but all of our combined insights and who knows what resources would be so helpful. So I'm really feeling constrained in this context to learn as much as we can. So thanks for doing it. We'll try to figure out a way to be responsive. I just hope today that we all have a little deeper understanding about what age does have to do with this. And there's some real things, and there's some things that is more about all of us than older people. And I just appreciate the opportunity to share these ideas.
One last question, because it's a good one. It says, I'm concerned about the minority populations and communities of color and those living in poverty are at a greater disadvantage. And what advice do you offer?
Absolutely. One of our guiding principles in our social work and public health programs and policy programs are the intersectionality of vulnerabilities. So older adults times poorer older adults times older adults coming in with a history of marginalization, health-wise or policy-wise, absolutely have more risk. So yes, very, very important point. And more likely to be in professions that where they're who can work at home is quite a privileged group of people. And I'm among them, that I can be on a computer and Zoom all day doing my work. People who can't are out of a job, or they're out on the front lines doing the work that they do.
Yeah.
We need to be worried about them.
Nancy, I want to thank you so much for taking the time today to share your expertise and insights. It's been such a really rich discussion. I want to thank our attendees who have really posted such thoughtful questions.
Absolutely.
And really allowed the conversation to go really deep. And now I want to just introduce the Dean of the Brown School at Washington University in St. Louis, who has joined us today, and it's Dean Mary McKay.
So thank you. Nancy, that was unbelievable. I've been able to join for the last kind of 45 minutes. And what I'm so grateful is to call you as a colleague, for you to pull together this kind of information, but also to be embedded in a community that I know it doesn't feel as good chatting with them remotely, but oh my gosh, the thoughtfulness, the generosity of the questions, the sharing of resources immediately. I feel just really humbled and privileged to be part of this community. I do want to also thank Janet Gillow, Gary, for your support. This open classroom concept came out of a very specific request from some of our community-based organizational collaborators that said, we have so many people working from home. Can't we use this as an opportunity to connect, to be together, to share resources, to be better and better at our jobs? And that's what's actually going to be needed for social work professionals, public health, social policy practitioners, that out of this experience, there's going to be more vulnerabilities, more harm, more opportunities to do good, and to course correct some of the equity issues within the systems that already exist. And so Nancy, you sharing that information and really putting ageism and the intersection of ageism and poverty and racism in one session, I'm incredibly grateful. I'm going to do a session, I believe it's Thursday, if I'm right, and I'm going to take us to the other end of the developmental spectrum. I'm going to talk about children and their families, and this being both a time where vulnerabilities may emerge or get worse in terms of children's health, children's mental health, but also what are the opportunities that exist to meet those needs. And so I'm super excited to be able to talk to this group and many others. So thank you so much for organizing this platform. Thank you.
Of course, we look forward to participating in your talk on Thursday, Mary. Janet, could you share with us just the profdev email address? If folks have any feedback or thoughts about today or suggestions for us moving forward, we would love to hear them.
Absolutely. So the departmental email is monitored these days, 7 days a week, and we're at profdev, that's PROFDEV, short for professional development, at brownschool.wustl.edu. Most of the folks on this meeting have received confirmations from us, and it really is just as simple as replying back to anything you've ever gotten from us. We take all of those responses seriously, and I'm going to be stretching my technical muscle to save the chat that's gone on and see what we can do to clean it up and create a resource that pulls together all these really wonderful suggestions.
Terrific. Thank you, Janet. And thank you again, Nancy and Mary. And we look forward to seeing everybody on Thursday, same time, same place. See you then.
Stay safe, everybody.